So today we'll be discussing about a very important topic, the acute ischemic stroke, and it is perhaps one of the most important medical emergencies which we encounter almost in our day-to-day lives in the emergency setup. So this is the basic overview of what we shall be discussing today, the patient selection and the imaging modalities being used for acute ischemic stroke, and along with that we will touch upon the topics such as what are the criteria and which all patients are suitable to undergo procedures such as a mechanical thrombectomy. So in the course of this next 15 to 20 minutes, we will come across certain clinical and radiological scoring systems which might look complex, but I will try to simplify as much as possible. So the first clinical scoring system which we shall be discussing when it comes to acute ischemic stroke, again we are talking about ischemic stroke and not about the hemorrhagic stroke here. So the first clinical criteria that is being used right now in present scenario is the NIHS score. So the basic criteria in this is that we assess when the patient comes in an emergency setting and a stroke is suspected, we give scores according to the deficit the patient has, and the crux of this particular scoring pattern is that the more the score is, the more is the clinical deficit. That helps us to decide what kind of therapy the patient will eventually have. Again, another clinical scoring is the modified ranking scale. It basically tells us about the disability status determined at the discharge and again at 90 days, because most patients who achieve functional recovery do so within this time frame. So an ideal time to undergo to have a mechanical thrombectomy is somewhere between NIHS score of 6 to 25 and modified ranking scale of 0 to 1. Then what is the age? Which patients of what age should be having treatment? So there is no as such cutoff for mechanical thrombectomy perhaps. Medical treatment we won't be getting too much into it because it is basically dependent on the time. Anything which falls in the golden criteria of 4.5 hours and has a stroke and has a clear-cut evidence of stroke should undergo the medical therapy unless it is contraindicated in a few selected cases. But for mechanical thrombectomy, we have certain guidelines which need to be followed. So right now there is no cutoff for the upper age limit, but perhaps as the age increases, the outcome of the treatment is likely to decrease. So pre-treatment imaging with acute ischemic stroke, how will we establish a stroke? Why is imaging important? Because it allows us for the assessment of intracranial hemorrhage. A simple modality like a non-contrast CT will tell us whether it is an ischemic stroke or a hemorrhagic stroke. And then certain higher investigations like CT angiographies and MRI and MR angiographies can tell us exactly where the site of occlusion is. And the studies like CT and MR perfusion can also tell us whether the tissue is salvageable, the brain tissue which is undergoing infarction, how much of it is salvageable and whether the therapy will work or not. So according to the 2018 American Stroke Association recommendations, it is reasonable to perform vascular imaging before performing a renal function test in patients without a history of renal impairment. So they say कि भी हमने RFT नहीं हुआ है patient का, contrast देना चाहिए नहीं देना चाहिए. That should not be done in emergency situations like that of a ischemic stroke. If the patient has had no prior history of renal dysfunction and the patient has presented with stroke-like features, immediate vascular imaging should be and must be done in all these cases. So on NCCT, how do we identify what are these fancy signs which we see on NCCT? What are these signs of ischemia? It can be some insular ribbon sign, lentiform obscuration sign, disappearing basal ganglia, focal hypotenuation, cortical sulcal effacement. These all hi-fi terms, basically what it means is that the gray-white matter differentiation is basically lost. That is the first and foremost feature which helps us to identify that an ischemic stroke is happening. So in these few images here, we can see basically that this is the lentiform area which is being obscured. The cortical, the insular ribbon is lost. And again, in this last image, we can see that the middle cerebral artery on the left side is appearing bright as compared to the right side. So this bright linear structure is nothing but the clot within the proximal segment of left MCA. So these are few features with which we can determine how a stroke appears, especially an acute ischemic stroke, the early ischemic stroke appears. And then we come on to a very important radiological score, which is called the aspects. What an aspect score is, that for the anterior circulation especially, we divide the brain in 10 zones. And for each area where we see that the stroke is happening, we keep on deducting points. So basically aspect score of 10 means a good brain, a healthy brain, and an aspect score of 0 or 1 would mean that a large volume of the brain has been involved with and is going to get infarcted. So basically why this aspect score is important? It helps us to decide whether medical as well as endovascular treatment is recommended or not. And a score of greater than 6, basically a lot of trials have happened and are still ongoing, and they have reached to this conclusion that an aspect score of 6 basically gives a good prognosis with medical as well as endovascular treatment. Then similarly for posterior circulation, the primary aspect score was for anterior circulation. So if there is a posterior circulation territory stroke, for that we have something called the PC, or the posterior circulation aspects. Again, it is based on the similar principle, a 10-point scoring system, but this time instead of the areas of the anterior circulation, we will have the posterior circulation areas like the brainstem and the cerebellum. Instead of the 6-point scoring of aspects, we will have the 8. Anything above 8 is good outcome, and below 8 means it will have a poor outcome. Then the next imaging modality we use is CT angio, which is perhaps a very important modality to decide whether one should go in for a endovascular approach or a mechanical thrombectomy. What a CT angio helps us to helps us in identifying the exact site of the thrombus, as to which vessel is involved, whether it can be approached through endovascular route, and whether it can be retrievable, the clot can be retrievable or not. All of this information we can have a fair amount of idea with the help of CT angiography. And there are various types of CT angiography which can be done. The most common one being done these days is the single phase CT angiography. It is nothing but just a plain contrast is given and a scan is acquired one time, and that gives us the information of the clot, where the clot is, and how we can go about it if we have to go in for a mechanical thrombectomy. It also gives us information about the clot burden score. Clot burden score is nothing but the number of vessels in which the clot is present. It is again a 10-point scoring system. The more number of vessels filled with clots, the lesser is the score. So basically lower score means lower functional outcome, larger final infarct volume, and a higher risk of parenchymal hemorrhage. CT angiography source images, again, as we can see in this particular image, the contralateral side has good perfusion, whereas the infarcted area, we can see that there is no perfusion whatsoever. So this is one of the important advantages of doing a CT angiography, single source. Also, we can have a fair amount of idea with the collaterals about the collaterals of that area with the CT angiography, because a patient who will have a good collateral circulation, we will have more time in that particular subgroup of patients who have good collaterals to act upon, because the perfusion while a stroke is happening will be maintained with the help of collaterals for a longer time against those people who will have bad collaterals or poor collaterals. And for collateral scoring, the better modality to use is a multiphasic CT rather than a single phase CT. So in multiphase CT, what the main difference is that we acquire the CT scan after giving contrast repeatedly for 3 times. So once an arterial phase is acquired, followed by a capillary phase, followed by a venous phase. So if we acquire multiphasic CT, even if there is delayed filling of the collaterals, we can have a better idea of the collateral circulation, and that will help us to decide as to how the treatment will help and how much time we have when we are proceeding towards the treatment. So this is again the collateral scoring systems, which is basically the higher score depicts that it is a good collateral, and 0 meaning the collaterals are basically absent. Then comes another very important topic, which is the perfusion imaging. So why is perfusion imaging important? It is mostly important when the stroke is outside of the golden window of mechanical thrombectomy, which is mostly considered as the 6 hours. So any stroke which presents after 6 hours of onset. So in this, perfusion imaging is recommended. Why is it recommended? Because it helps us to delineate what is the amount of core. What is core? Core is nothing but the tissue which is already dead and it cannot be revived. So perfusion helps us to decide how much is the core and how much is the penumbra. What is penumbra? Penumbra is nothing but the tissue salvageable. The salvageable tissue which can be revived if we give proper medical therapy or we give the endovascular therapy or both. And then there is an entity called benign oligemia. Perfusion also helps us to delineate that, because these benign oligemia patients will respond on their own without any therapy as such. So these are the perfusion parameters, the relative cerebral blood flow and the cerebral blood volume, and the mismatch between these parameters, the clinical cerebral flow and the volume, will help us to decide which part of the brain is the core and which part of the brain is penumbra. And these are some basic profiles, and the ones we will target in this on the perfusion imaging are the target mismatch population, in which there is a relatively small core, higher sized penumbra, and the PC mismatch ratio, which is the core to penumbra mismatch ratio, is greater than 1.2 to 1.8. Again, these are all automated softwares which are available, which help us to decide which are the patients that have to be undertaken and which need medical or endovascular therapy. So then what is the role of MRI imaging when it comes to ischemic strokes? MRI imaging is very important, but due to the limited availability of MRI in all setups, it is not being used so often. But the most important sequence or perhaps the most sensitive sequence which is being used nowadays is the diffusion weighted imaging. It is one of the sequences which can catch strokes even after like half an hour of onset, and there is no other modality which can pick up acute ischemic stroke so early. And then there are other sequences such as FLAIR and gradient echo imaging, which also helps in assessing the stroke. So diffusion I have already talked about. What is the importance of FLAIR imaging? So suppose you have a clinical scenario where a patient goes to sleep totally fine, no deficits when the patient went to sleep, and when the patient woke up, you suddenly see that there are clinical deficits, there are significant neurological deficits. In these particular subgroup of patients, we don't know when was the actual time of onset, because stroke happened sometime during the sleep. So to decide whether the patient is still in the golden window, we will look at the diffusion images, which will tell us about the exact area of the stroke, and we will try to match the same pattern with the FLAIR imaging. So if there is a diffusion FLAIR mismatch, basically meaning that the stroke is fresh, there are bright signals on DWI images, no corresponding bright signals on FLAIR imaging, go in for the medical management right away, because the patient is in a golden window period and patient can be saved from significant neurological deficits. Susceptibility imaging will help us to delineate the clot. Just like CT angio, it is another modality with which we can see the clot as well as the microhemorrhages present between the infarcted area. All these things can be depicted with the help of a susceptibility weighted imaging. Again, an MRI based sequence. So the early window, as I already talked about, aspect score of more than 6, patient having a large vessel occlusion presenting within the 6 hours of onset, symptom onset, having a small core and a large penumbra, one has to go in for a mechanical thrombectomy, no questions asked. The problem lies when the patient falls outside of the 6-hour window period. In these particular subgroup of patients, which is mostly the case because very few people present within the golden period, in these particular subgroup of patients, there have been 2 very important trials which have happened, the Dawn and the Diffuse 3 trials. And according to these these trials recommend perfusion imaging, and they have laid certain criteria as to which patients after the golden window period can undergo endovascular treatment. So these are some other landmark trials which have happened. Still a lot of work and research is still being done, and it is a ever evolving topic. And there are some subgroup of patients with limited evidence. What are these subgroup? Patients with a score, NIHS score of less than 6. Basically, they have good collateral circulation, and again we have very limited work in this, whether endovascular treatment is beneficial in this particular subgroup of patients. Again, in large ischemic core, where already the core size or the dead tissue is large and there is very less viable tissue, whether to go in for a vascular therapy in such cases or not, endovascular therapy in such cases or not, that is a question mark still. But the trials which have happened, they have shown that it does have a good improved clinical outcome even if we go in for endovascular therapy in such cases. But there is no criteria as of now, established criteria. Same is for the case for posterior circulation stroke. The BEST trial has happened, but again main work or the higher still a lot of trial work is still going on. And same is the case for a distal vessel or small vessel occlusion. The main problem with distal occlusion is it is difficult to access these smaller vessels and to retrieve the clot from these smaller vessels. So to summarize, what we have discussed is age group more than 18, modified ranking scale of 0 to 1, NIHS between 6 to 25, aspect score of more than 6, large vessel occlusion present, and time less than 6, go in for the endovascular and medical treatment. Between 6 to 16 hours and 6 to 24 hours, you have to decide on the basis of perfusion imaging whether to go in for a vascular treatment or not. And this is a complex looking chart, but it basically signifies the same thing. Also in cases of wake up stroke, we can take the help of MRI and decide which path to follow. And this is how we can make a difference. This is a patient who presented within the golden window with the right MCA cutoff. There was no circulation. There would have been a large infarct in the MCA territory with with disability for life, but with suitable therapy and mechanical thrombectomy, we were able to recanalize the whole thing, and the patient improved on table and walked out of the hospital with no deficits whatsoever. I thank you all for your very patient listening.